We're just going to wait for a couple more seconds till everyone gets in the room, and then we'll start in about a minute. Okay, happy to start. Good evening, everyone. My name is David Cummins, and I am part of the Australian Health Design Council. We are pleased to have you all here tonight, and we have got great interest in our topic tonight, which is My Kitchen Rules, Designing for a Sustainable Future. We'd like to begin tonight by acknowledging the traditional custodians of the land in which we meet today around Australia. I would also like to pay our respects to elders past, present, and emerging. We'd also like to thank our sponsors for their continued support for the Australian Health Design Council, foundation partners In Vitro Technologies, Katingi, and Enware, industry partners including IPG and Stereos. Introducing our topic tonight, we have My Kitchen Rules, Designing for a Sustainable Future. In 100 years, our hospitals have transitioned from providing minimal patient food to being the sole provider of appealing nutritious meals to aid recovery. Hospital food services operate in a challenging environment, doing more with less, supporting planetary health, meet nutritional patient and food safety guidelines and national accreditation standards, and achieve a favourable bottom line. Globally, hospital food waste can contribute to up to 50% of total waste generated, with plate wastage ranging between 6 to 65%. The good news is that we can do more and we can do better. Learning from the hospitality sector, we are redesigning our kitchens, workforce, and workflow to support planetary health. Despite the long lead time, private and public healthcare in Australia and overseas are nonetheless transitioning to more flexible approaches such as room service. The results highlight positive outcomes to support a sustainable future. Plate waste reduced by more than half, improved patient experience and intake, and reduce food cost. Today, we will discuss these approaches and what this means for designers and decision makers. Before we start, I would like to share some housekeeping rules. During and after the presentation, attendees will be invited to send their questions using the Q&A button at the bottom of the screen and participate in a moderated Q&A. After the presentation, we encourage you to stay online to share your thoughts and continue discussions in an informal setting as a Q&A. The recording of this event and the presentation will be available in the next week on our website for members access only. The discussion session following the event will not be recorded. Architects, project managers, and engineers can claim continued professional development points from today's sessions. Details can be found at the event information email. For architects claiming formal points, a link was provided during the registration email. Tonight, I would like to welcome our speaker, Carmel Lazarus. Carmel has a postgraduate qualification in business administration and nutrition and dietetics, and is an experienced professional with strategic, operational, and project management expertise, managing food, dietetics, and allied health teams in Australia and overseas, as well as consulting to aged care communities and industry, and whilst also lecturing at Sydney University in Nutrition. Carmel is a project consultant for Seaboard, partnering with customers in designing efficient food and nutrition models. Her interest lies in facilitating teams to maximize good nutrition and patient experiences. through innovation and sustainable food service systems. In her spare time, you'll find her on a bike, riding, traveling, and supporting the Sydney Swans. We welcome Carmel tonight. And just as an aside, just for those that don't know, Carmel and I worked together at St. Vincent's for many, many years. Highly recommend listening to her tonight, and cannot wait to hear more about this through her research and her expertise and passion in this industry. So welcome, Carmel. We look forward to hearing you.
Thanks very much. Thanks, David, for the introduction. Take over the reins. Okay, well, thanks for the opportunity. I'm really excited to be able to shine the light on a particular service in healthcare, which I feel gets very little focus, but makes significant impacts to the patient experience, health outcomes, environmental and organisational benefits. So today we will cover a bit about the hospital food service operations and how they've changed over the last 100 years or so to today, the impact of this on the patient experience. What are some of the challenges that food service operators face to meet all the requirements? And then the opportunities that we have to create a more sustainable model for the future. So let's start with Hippocrates. So Hippocrates recognised very early on that importance of good nutrition was part of the patient's medical therapy and treatment. And while our focus today is very much on healthcare, I think this philosophy certainly rings true for the aged care sector as well. Unfortunately, over the last 4 to 5 decades, we've seen the function of food services in hospitals become very much divorced from the clinical care that patients get. And it's very much seen as a business unit, a support service, or a hotel service. And our hospital patients are captive audience. They're like airline passengers. And for those who've been lucky enough to travel, we've experienced the demise of airline food. But as a passenger, we are generally well, and we are captive for less than 24 hours. But food comes to patients at set meal times, and they need to order way in advance, and they have a very much a changing appetite and changing condition, whereas when we're sitting in an aeroplane, we're well, and we don't have any of those complications. So I think we need to acknowledge that no nutrition is provided if the patients aren't actually consuming what they eat. And in spite of the menu looking glossy and meeting all of the nutrition standards, if the patients aren't actually consuming it, they're not really getting, or they're not getting any nutrition. So if we look at the pictures at the top, the two ladies, you can see the woman on the left. She came into hospital from the community very underweight, undernourished, had a poor quality of life. She had infection, terrible wound healing. And the picture on the right is the patient, same patient, leaving hospital some weeks later with a good quality of life. Her infection had been cured, her wounds had been healed, and really her only treatment was a review of all her medications. So she was on a multitude of medications, and good nutrition while she was in hospital. So I think food is medicine, and cheap medicine. So I think it's important that we really see that as a clinical service. So if we go back to how hospital food services has changed over the last 4 to 5 decades, I think we can see that it was very much a medical and nursing supervision where food services was provided. If we looked at around about the 60s to the 80s, and hospitals food services was overseen by doctors and nursing staff. clinical diets were prescribed based on the patient's therapeutic diet needs and the condition that they were in hospital for. And food was carefully weighed out and portioned and plated up, and then the food was delivered, and the patients were monitored for what they actually consumed. So the food and the fluid that was consumed. So there was not only the provision of the food, but also a surveillance or monitoring to see that the patient actually got the nutrition that they needed. So all the hospitals had their own kitchens and they provided the food on site. It was cooked at the time, heated and served. And then we moved to the 1980s, where we saw changes in hospital kitchens and the advent of cook-chill technology. And cook-chill technology enabled food to be produced in bulk as well as in advance, and it could be produced on site or elsewhere. And because of the food safety guidelines that the food was produced in, it could be transported for a period of time. It could be served following it being chilled. And so it gave the patients a lot more variety in terms of what they could have for the next few meals. But then hospital kitchens became very much like, I guess, food manufacturers. And some hospital kitchens decided that if there was one particular big kitchen in their area, then every hospital didn't need to have a kitchen. And so the infrastructure of the kitchens within hospitals changed, and a number of hospitals ended up closing their kitchens because they received food from elsewhere. So many area health services became mini production kitchens for some of the smaller hospitals within their group. And we've seen this continue where the hospital food services is not always produced on site. So if we think back to around the 1990s, about half the hospitals in New South Wales and a significant proportion in Victoria also became big manufacturers of food and food production kitchens, and so they provided food to other hospital kitchens. And I guess this freed up some of the real estate for the hospitals, but it meant that they no longer had the flexibility of providing food sort of in a short order, on-demand capacity for those patients that weren't necessarily managing the food that was produced in bulk. So if we skip forward to around the 2000s, we saw an increase in the use of technology to be able to provide the food services. And what we also saw was patients were able to order at the bedside. So there was a meal ordering system, a spoken menu that was provided. And more patients were coming into hospital during this time who seemed to be underweight and undernourished. However, the food service guidelines and the nutrition guidelines were very much about providing a lower fat, reduced salt type of diet to help those patients who were in hospital with heart disease and diabetes. So there were different patient cohorts where the food services needed to be able to provide the food for both types of patients. And, you know, that's usually what happens. There's usually a multitude of different nutritional requirements from different patient cohorts. But the problem towards the 2000s was that because a number of kitchens had reduced their footprint or removed some of the kitchen infrastructure, they no longer had the flexibility to be able to provide food services that would meet the needs of all the different patients within their cohort. And then what we saw was an increase in usage of nutritional supplementation and a move away from a food first approach. So patients were no longer able to have comfort food that they were used to having from home, and they really relied on some of that supplementation to meet the nutritional needs to help with their recovery and get over their operation. So then we moved to 2010 and 2020, and there was a call to action really from clinicians, but also from patients themselves that were demanding a better food service. They saw that the food that was being provided did not necessarily meet their needs. They wanted food that would aid in their healing and be part of their therapy. And they also wanted to ensure that there was not the wastage. Patients were needing to order quite a bit in advance, so at least 24 hours in advance. Now, patients ordering that far in advance, they were usually sick, their appetite was poor, and so they didn't really know what they felt like tomorrow. You and I are well, and we don't know what we feel like eating for lunch tomorrow, yet we were expecting patients who were unwell to decide the day before what they felt like eating. So as a result, everything was ticked on the menu, everything on the menu was provided, yet the patient didn't consume much of what was provided. So this led to quite a lot of wastage. So a long lag time between meal ordering and meal delivery, as well as a high wastage. So during this time, there are a number of standards that were developed to improve the nutrition that was provided. And there was more evidence of emerging models of food services, which was going to be more sustainable for the future. So I guess if we don't look at more sustainable models for the future and we continue down the road that we're providing the food service as business as usual, we know that there's a significant proportion of malnourished patients which come into hospital. And this has very negative outcomes. The patients generally have poor wound healing, they have longer lengths of stay, there's a higher healthcare cost for these particular cohorts of patients. And now malnutrition is recognised as a hospital-acquired complication. So up to 1 in 2, 1 in 3 to 1 in 2 adult patients, the research shows, come into hospital as malnourished. And a poor intake is an independent risk factor for increased morbidity and mortality. As well as that, 5 times higher inpatient death rate for those patients that are poorly nourished. And of course, an increased cost in the management of patients with malnutrition. So some hospitals, pleasingly, have provided some inroads into improving hospital food services and hospital nutrition. And I'll let you look at the photos to decide which one of those hospitals or which one of those plates would be something that you'd be willing to eat. I won't mention which one, but one of them was my daughter's meal that she received in the children's ward a few hours after surgery, not appropriate for that particular patient cohort. And these are real photos of hospital meals that are provided to our hospital patients today. So I guess what we need to think about is how do we actually come back from the 80s and 90s when we saw that transitioning from hospitals actually producing the food from that centralised food service and food manufacturing model. And I think if we are to move to a more sustainable model, and I know with my own former organisation where I worked, the conversation needs to start really early. And some hospitals today may be designed without a centralised kitchen, and they may have pantry-based models, and planning and appropriate planning, and if managed well, these models too have documented improved patient satisfaction as well as reduced waste. And there isn't one size fits all. It's very much an assessment of each site and what each site's needs are. But I guess we do need to be mindful of the long lead time in the planning process, as I'm sure you all are aware, for that redevelopment. And this is something that we do. We work with sites in the design and implementation of a new food service model. And often we come in quite late in the process where the design has already been done. I know a particular hospital which was having to get a new kitchen because their kitchen was being going to be used, the footprint for theatres. And the type of kitchen that was going to be implemented was a cook chill kitchen. So food would be prepared, chilled, cold plated, reheated and delivered. And there wasn't even any discussion with the business unit about whether that was the appropriate model for that particular patient cohort. Luckily, we hadn't got too far down the road and we were able to look at alternative food service models. And we actually looked at room service because the footprint that was required was less. So we were able to actually implement room service for that particular site. So it's about getting in early when we can, greenfield sites or brownfield sites, and being in that conversation right at the start. So what are some of the challenges that are faced by our food service operators? And they are many and varied. And I think if you're a food service operator, you're very good at balancing lots of competing priorities. The demand is that the patients need to have the right meal delivered at the right time, correct temperature, and delivered to the right patient. So there's certainly expertise amongst food service operators to be able to do that. But I think there is a certain level of complacency about doing the same as what we've always done. But we know doing the same as what we've always done has higher cost, doesn't necessarily provide the patient satisfaction, but also has significant impacts on the environment. And it's not really sustainable for the future. We know if patients are ordering a long time in advance, that contributes to significant food wastage. So I think there's lots of standards that the food service operators must comply with. You've got food safety standards, you've got nutrition standards, there's various quality and safety standards for accreditation, engagement with consumers. So there's a whole lot of areas that food service operators need to take into consideration. But I think we know that the current model is not necessarily fit for purpose. If a patient's ordering so far in advance, by the time they get their meal, their bed number might have changed. They may be in a different location. They may have been discharged. Their diet might have changed. Their appetite's changed. So again, that contributes to high waste. The other area which food service operators are challenged by currently is the workforce. So we know in the hospitality sector, and it's no different in healthcare and aged care, that there's a huge shortage of staff. So, I mean, you know, if you go into a pub and you see the QR code and that's your way of ordering, and that business is able to then direct their staff into the actual production of meals. So I think the ability to use technology, because there's a real skill shortage for food service operators. And when I talk to food service managers around the country, they're some of the key things that they're facing at the moment in terms of not just finding the right staff, but with the right skill set. And then matched with that, obviously consumers are expecting a lot more. Our patients are expecting nutritious meals that are going to help aid their recovery during their hospital stay. So we want to make sure that we're providing a sustainable food service operation, and hospitals really have a duty of care for human health, and human health relies on planetary health. And I think if we look at the Global Green and Healthy Hospitals goals, we can see that food services touches on a lot of the goals. So you can see leadership, chemical usage, waste, energy, water. There's some great initiatives out there, and particularly in use of equipment in terms of saving water. Food, purchasing food, maintaining food safety so that we're not having to throw out food and not over ordering and overproducing. Then, of course, our buildings, which is also why we're here tonight, talking about how we actually build to get effective and sustainable food service models and purchasing. So the idea is that we want to try and be smarter with what we're doing, and we know that the ideal is to prevent or reduce the waste that we're already contributing. So these are just some statistics which I thought would be interesting for you to see. And a lot of hospitals don't even know what their wastage is. They don't know how much waste is going into landfill. They don't know what sort of weight their waste is, but on average 20 to 30% of hospital waste is from food, and that's quite significant. But the range is 17 to 74%, and this was in a recent systematic review done in 2020, and it was sort of just as COVID was happening, and we saw quite an increase. The research shows that there was an increase in wastage with COVID, just because of the way food service was provided and the need for infection control, particularly early on when there wasn't that understanding. So significant waste coming from hospital food. And the food waste streams are from what's produced. So making sure that we're not overproducing, over forecasting, but also trays going up to patients that really don't need to eat, don't want to eat, and maybe they've already had a snack or had something else, or they're just not feeling like eating. Maybe the meal comes at 12, but they usually have their lunch at 2. Maybe their diet has changed. So the tray wastage, but also plate wastage. So the food that is going up, what is going up is not fully consumed. So they're the different waste streams that contribute to that overall hospital waste. So not only is that an issue environmentally, but also financially, and also all the resources that go into producing that food that's then wasted. So hundreds of thousands of dollars potentially that increase the cost of the food service model provision. And tray waste can be as high as 20%. So some of our sites where we implemented an on-demand room service model, that 20% went down to almost zero. So a significant reduction in the amount of waste. So what are our patients actually telling us? What do they want? So this is some feedback which has come back from, which was presented at some workshops that we did with various staff and consumers within Queensland Health and ACT Health. So the patients aren't looking for anything outlandish. They'd like packaging that is easy to open, particularly patients with poor dexterity or frail that are having difficulty opening packaging. A lot of food service menu items are in portion control, so difficulty opening, and then that goes into landfill and waste. They want to be able to eat when they're hungry. So not being able to provide, not just having food when it suits the organisation, when it suits the ward, but to be able to access food when they're hungry, because the research shows that they actually consume better when they have food when they're hungry. More culturally appropriate food, a meal choice that's close to the meal time, so not the 24-hour plus in advance that we currently see in many hospitals, and food like at home, so fresh and different textures. So what we're talking about today, where we've seen some great benefits, is on-demand room service. So the initial drivers for what we've seen in Australia and New Zealand to date has really come from North America. A 2016 survey in the US showed that up to 48%, so nearly half the sites were using or were moving towards a room service on-demand system. And that was up from 2006, when it was about half that. So it was about 25% in 2006 and went up to about nearly 50% in 2016. So what we mean by an on-demand room service is where patients get to order to appetite. There's an a la carte menu, so it's a one-day menu, but has many choices, and patients can mix and match what they're ordering. So if you want a particular meat dish with a particular sauce, you can mix and match. And the idea is that it's an integrated menu with as many diets as possible. So you're not having to do a whole lot of different items for all the different diets that you're providing for. The ordering system, hospitals use a different variety of systems depending on what the site is set up is. So it might be a patient engagement system, might be bring your own device, or it might be via the phone to a centralised call centre. So the meals are assembled and cooked to order once the patients place the order, and then the meals are delivered within a set time frame. So there's no longer any set meal periods. The information that's received by the kitchen has been connected up to all the dietary and allergy information, so as well as information about the patient's location and other information about their dietary goals. So what we've seen in Australia is the first room service was implemented in 2013. And then from there, we saw an increase in the implementation, but mainly in the private and not-for-profit sector. And it wasn't really till 2019 when room service was implemented at a Queensland health site, so the Prince Charles Hospital, which is a large quaternary hospital. And it wasn't really till then that we started to see growing interest in room service as a model, and people wanting more information about it, and sites looking at whether their site would be suitable to implement room service. So room service is really about turning everything on its head and reimagining the patient meal journey. So instead of the organisation demanding and the business demanding the meal period times, it's the patients, it's patient driven. The patients are ordering to appetite, but based around certain periods. So generally from 6:30 in the morning till 7 at night, patients are able to order when they want. It's a mixed model in some hospitals, so it depends on your patient cohort. So you might have patients that in mental health, they might receive the same menu as those patients on room service, but perhaps because of their medications, they need food at set times, so they'll receive the same menu items but at set times. So it just depends on the patient cohort. But I think if we're looking at hospitals and hospital function, patients are often returned from surgery quite late or admitted quite late, and often there's nothing for them to eat when they return from surgery or admitted. So I think it's about making sure there's some flexibility. If a patient's returning from recovery at 2 in the afternoon and they just want an omelette, the ability to be able to provide things like that, rather than not have any items and have to wait till the next meal time, which is usually at 5 o'clock, which is dinner time, which is quite an early time for a lot of people. So this model is also supported by technology. So patients, you can order through a patient meal ordering app, and then there's information that transfers into the kitchen, as well as a tray tracking process so you can basically follow the tray from plating up right through to delivery and collection. The importance about an effective model also is that it's chef-led. The chefs have the expertise in terms of running the kitchen, so they're involved in part of the planning and the design, the menu, and the business processes and training of staff. So we have chefs on our team that work with sites to implement that. And the other key part of ensuring that this reimagining actually can be embedded is to get that executive and clinical buy-in, because without that buy-in, the model's never going to work. So it's really important to see this change as a hospital-wide project and not a food service project. And then we also have a data analytics or surveillance tool. So when patients' trays are collected, we have the ability to collect information about what the patients consume. So we have their nutritional intake. We also have wastage data, and that helps to feed back into whether the patients receiving a good menu, whether they've liked the menu, whether they liked the item but they on the menu, but when it came to delivery they didn't consume it. So all of that information is fed back to help the food service operators in their decision making. So this is just an example of the room service flow. So the patients place the order. If it's a call centre, they'll ring through to a call centre. Tickets will print in the kitchen, and there's a particular setup in the kitchen with similar to what you see in a cafe style, restaurant style, with a pass and a cooking on one side and meal assembly on the other. The meals are prepared to order, and then the trays assembled, placed in the trolley, and depending on where it needs to go, then delivered to the patient. And then after a certain period of time, the trays are collected and information is collected about the consumption on that tray. So this is just some examples of some customers in Australia and New Zealand that we've worked with on the implementation of room service. Seaboard is a global company, and a lot of our customers are in America. But in terms of our team here, these are the hospitals that we've worked with in the implementation of room service. So this is all good and well, but what does the research say? So it sounds really good, but we need to make sure that what's actually anecdotally what we think is good is actually happening on the ground. And really, when patients are left to decide for themselves what and when they want to eat, their satisfaction improves, their nutritional intake improves, and the food waste decreases. But the other thing is the cost of the food service decreases, because there's a significant cost tied up to overproduction and food waste. Hospitals have saved on their food service operating costs. So in terms of nutritional intake, energy and protein intake have increased by up to 47% with this particular type of model, as well as improved intake as a percentage of nutritional requirements, as well as reduced food waste. So the sites implementing room service have reduced their food waste by more than half. And again, depending on the site, different sites have experienced different food cost savings. Again, it depends on the baseline of what food service model you have. Some hospitals have saved up to 28% in transitioning to this model. So these are some of the research papers that have been published, and both in private as well as public hospitals. So it's not just a private hospital initiative. We're seeing more public hospitals now implementing this. And I'm just pulling out 2 hospitals to give you an idea of specific case studies. So the Prince Charles Hospital. So this was the first large public hospital that implemented room service. So we worked with them from planning and design through to implementation and evaluation. So they went from a cook freeze and then thaw and then reheat model, food service model, to an on-demand room service model. So quite a redesign of their current kitchen, and providing food to 600 patients. Their kitchen needed to continue operating during this period. So very much a phased approach. So you can see significant reduction in food production waste, improved nutrition and energy intake, reduced plate wastage. So it's not unusual for sites to have 30 to 40% plate wastage. So great to see sites that have room service often have plate wastage at well below 15%. This hospital also received an excellence award by the chief executive, and what the chief executive commented on with this project was that not only was, of course, it was patient-centred, but they thought it was a great example to other areas within the hospital that if something is patient-driven and the processes are not based around what the hospital itself needs, but what the patient needs, then we can still get some great outcomes. So this model also saved the hospital department money, as well as improving patient satisfaction. So really ticking all the boxes there. In terms of the Mater Hospital, so this was a 220-bed private not-for-profit hospital. So significant reduction in waste. So 2.5 elephants worth over a 3-month period. So we had our waste disposal contractors weigh the waste, so we could see what the reduction in organic waste was. Improved nutrition. Plate waste also reduced 28%. Generally, private hospitals tend to have a slightly lower plate wastage because they're not as sick. It doesn't have the acuity that some of the public hospitals have, but to 8%, reduced to 8%. Quality awards won for this room service implementation. 17% cost savings in terms of the food service operating costs, and also improve revenue. So what this system allowed the hospital to do was to be able to provide guest meals, and that created additional revenue to the hospital. And they did this within the same staffing structure and within the same kitchen footprint. And it meant that patients were able to eat with their partners, and that often anecdotally improves their nutrition. As well as this, they had an improved patient satisfaction level. So where to start and what's our approach? So generally what we do is we do a phased approach. So phase 1 is really hospitals interested in looking at the feasibility of room service, but they really want to know what's possible. Is it possible? Can we actually do it? So we do a detailed review over about an 8 to 10 week period, and we look at a whole range of areas. We look at current state, we look at service output, service levels, we look at patient demographics, we look at the logistics, we look at infrastructure and other parts of operations. And we look at the model features that we think would work for potentially for your site. We do a costing analysis of what it would cost if we were to implement a room service. So we look at the workforce, we look at the staffing structure, we look at the menu, menu design, the food costs. We look at the requirements for implementing a room service operation. So we look at the equipment that's needed. We also look at the staff resourcing costs, the project costs, the technology. We do a concept design within the footprint that we have for the kitchen, and then we put all of that together and determine whether it's feasible to implement room service. And it may not always be feasible. It may not be feasible for every patient cohort. So what's the mixed model that we're going to provide if it's not suitable for the patient cohort? And then we determine that site's readiness to transition to room service. Then the next process is, if it is feasible, is to get in principle support for transition to a room service model, and then we go through our team work with the site architects. We have our own kitchen designers on team, or we can work with the kitchen designers from the hospital or from the consulting team that's been engaged. And we work with the site on planning the kitchen flow, and we design a menu. We look at the workforce. We look at the business process redesign. We do the construction time in terms of the technology, and we don't do we work with the builders in terms of advising, but that's a separate entity. And we're really doing the change management and business process side of the redesign of the food service model. And then we provide the training to staff, because it is quite a different model. It's a different model for everyone. So it's not just a different model for food services, it's a different model for the patients, it's a different model for the nursing staff. So we need to have buy-in. So we're involved in that whole project governance structure. And then we're on site for go live and provide support for go live, and then do some evaluation afterwards. So just finishing up in terms of next steps, I guess the thing to consider is, what are, for those people who are working within a hospital or partnering with a hospital, what are the consumers saying to us? Do they have a voice? Are they involved in service planning and service design? Is there an opportunity for redevelopment? Is that happening? Do you have an aging kitchen? Is there a campus master plan that's being developed? Can we have some input into that? Do we already have a sustainable food service model, or do we know whether our current food service model is sustainable? And I guess more importantly, do we know what our waste levels are? And I think that's a really good question to ask, and good place to start. And the other part is that advocacy. Start asking the questions, start planting the seeds, start having that conversation. And the last two slides are just feedback from patients that were received when we implemented room service in these particular sites. So being a fussy eater, really appreciate the ability to order from an extensive menu at a time of my choice. And from Prince Charles, it's very wordy, but basically you have precious little control when you lie in that hospital bed. So I know how wonderful it was to be able to order what you wanted when you wanted it. It made a world of difference. Thank you all for your tireless work. So that's it from me.
Thank you, Carmel. That was extremely informative. We've just got a few questions now, probably from about 10, 12 minutes. So thank you for that. What I really liked about that last slide, or the testimonial, is when people are so sick and they feel like they've actually got no control, you're actually empowering a lot of patients, which I think is really interesting. Did you do, I know you've said you did patient satisfaction surveys, but did you do anything about staff satisfaction surveys? Was that a component?
We did actually, when we implemented at the Mater, we did a review of staff satisfaction. And so we asked questions about current model and future model. What would they prefer and why would they prefer it? And I guess it was probably only about 3 months in, so the staff were still getting used to it. But the food service staff really liked it because one of their biggest concerns, particularly a lot of them are from, a wide range of countries, and for them to see waste, that was a really big thing for them, to see that reduction in waste. For the clinical staff, initially it was that loss of control because they know when the meals are coming, because they can smell whatever, I've got to give my patient medication. But, that's part of the, involving them in the process. And it was just a different way of working. And once they got used to that different way of working, and also the patients were able to advocate for themselves about, their insulin or whatever, if it needed to be timed with their patient meals. So the patient satisfaction was good. The only thing which is common feedback from staff is the amount of walking. So we kind of, some hospitals have had the staff wear pedometers, and they're doing a lot of steps because, you're not taking one meal over to one ward and then another meal over to the ward on the other side of the hospital. It's structured so that you're delivering within certain areas. But there is certainly a lot more walking than what there is in a traditional model. And I guess that's, where the logistics is really important, and your staffing structure and how you manage that. So fitness is not necessarily a bad thing, but they did comment how the soles of their shoes were wearing out quite a bit.
Yeah, it'd be a big change from, being sequential versus at need. So I can see that. We've just got a few questions from the team. From Megan, the historical timeline of staff food provision mirrors that of patients with recent food court models. Can patient food services infrastructure be shared with staff, or staff services run separately to assist with staff wellbeing? That was one of my questions as well. So from Megan.
So in terms of doing it sort of similar timelines, you mean?
Well, I got it, Megan, you can add, but my interpretation of that was similar locations, or you could mean timelines, but my interpretation of that was I was thinking about locations, but let's go locations and timeline.
Yeah, I think I think it is very much about communication and the planning. And we've had conversations about this before, and I think that staff need to be brought along the journey right from the beginning. And I think if they're aware of what's involved in the food service model from the beginning, then they have an opportunity to decide whether they want to be part of that or not part of that, or different roles come up and different opportunities come up for the staff. I think the other thing is, there's set time frames, and well, not set, there's obviously a roadmap and a project plan for implementation. And it can vary from 12 months to 2 years in terms of from a feasibility right through to implementation. And so there's lots of opportunities to plant the seeds, and there's also opportunities for staff to see where they might fit and what are some of the different staffing positions that they might be able to move to. So I think it's about that communication and keeping that communication going. And I think the people that we're working with on the project team and the managers, having that good communication with their staff is important. But I think the other thing is having champions throughout the organisation to help sort of build momentum and continue that momentum.
Cool. We've got a few more questions. So citations from the Neves paper, I think it's Neves paper, you mentioned seem to be nutritional publications. Is there any published literature in architecture or facilities, scholarly work or articles, so forth? So more from probably architecture, design point of view.
No, good point. I wish there was, but there isn't. And in fact, when we go to, since we implemented the first model here in 2013, we're actually asking architects to look at this design and working with the design and building up that capacity. So no, there isn't, but that would be good, wouldn't it?
Yeah, I know there's a few architectural researchers online tonight, so I'm more than happy to take that on board.
Yeah.
From Greg Angel, I don't know, it's from Greg Angel, who helped a lot with St. Vincent's.
Yep,
Have you looked
that name sounds familiar.
have you looked at the setting? Greg's so funny. Have you looked at the setting for eating in a hospital? Eating in bed always seems kind of gross, and I totally agree about eating in bed. So it's a really interesting concept as well. I know there's sometimes people that have to, but it is pretty gross when you think about it out loud.
Absolutely. And I think, I'm sure Greg's familiar with St. Vincent's, trying to, even in a rehab facility, get patients to come out of their bed and eat collectively in a dining room. And Stars is a really good example in Brisbane, which has been sort of a purpose-built digital hospital, so rehab and surgical. And they create a dining room. So they've got room service as well as a dining room. And it's a concerted effort by all the clinicians and all the food service staff. And it's actually the philosophy to get patients out of their beds, moving and getting them into the dining room to eat. And I think the difficulty is it's got to be a whole sort of a holistic approach with the clinicians and the allied health working together to do that. So I think you can, from your background, you can design it, but as we know, there's lots of dining rooms around, but they're just not used. And I think that's a shame, because I think the socialization of eating, there's a lot of reporting that patients' nutrition and well-being generally improves when they're eating with someone rather than sitting in a bed eating on your own.
I was part of a trial last year, I think it was, for a health hotel where they actually had patients come from hospital to hotels, and one of the positive outcomes of that was, because they were in a bedroom the whole time, or a hotel bedroom, they actually found that about 80% of people plus came down to the shared common community area to actually sit down with people, but the desk arrangement was very different. You could actually have a one-on-one or one or two set up, as opposed to a big table, which is what a lot of the ADL kitchens have. So it's probably something we can talk about in a design for some people want to be by themselves, but still in a social setting, because they found the rooms too isolating. So that's a good challenge for people.
But it's even something about getting out of the hospital bed into a chair. Even that is an important thing. And there's been a lot of research about protected meal times globally, and about getting the patient ready for their meal, and making sure that they are sitting out of bed, because that's better for their nutritional intake, well-being, that sort of thing.
Yeah, good one. We've got a few more minutes. So from Louise, broadly, have you found it easy to retrofit, this is one of my questions as well, to retrofit a room service model into an existing kitchen, so existing infrastructure, which is predominantly most hospitals? Have you, how much change to the physical kitchen environment is likely?
That has been most of my experience so far. I think at St. Vincent's Group, Prince Charles, they're all existing kitchens. I guess the thing is that they're aging kitchens, so there's an opportunity to redesign. It is quite stressful, because obviously you've got to keep up the continuity of the service, so having mobile kitchens and all those sorts of things, complicating factors. And also, once you start designing, what's in the roof and where the services are and everything, but it also depends on where the exhaust is, because that's a high cost, and what the exhaust is like. So all of those things need to be taken into consideration. So yes, there's definitely challenges. But the flip side of that is, if it's a greenfield site, which we've also done some designing with the site's architects and other consultants, is vying for enough a footprint, because they think, oh, well, you've only got this amount, and we know that that's not going to be enough, even though generally in room service there's less, because you're not procuring the same volume, the stock lines, you haven't got as many stock lines, so you're not needing to keep as much stock because your menu is very different. So there is less storage that's required from that.
We've only got time for, there's two more, but we'll just have to answer quickly. Sorry, Carmel. This was one of my questions as well,
okay.
but it comes from Leslie. Very smart. What were the major roadblocks for implementation? Very simple question because it sounds amazing.
Yeah.
So what are the inhibitors?
I think construction supply issues, especially over the last 2 years, that's been a big issue. Long lead times for equipment, building, so that issues with building, or in Queensland, for example, a whole lot of mold which needed to be remediated before we knew. So again, brownfield site, you uncover things that you sort of don't bargain for, and also just getting that buy-in, having those champions. If you don't, then that's going to be a big challenge. So, and I guess the other challenge is there's not necessarily, there's probably more now, but hasn't been that insight about the model. So you're really having to not market the model, but you've got to create that buy-in to get people on board.
That sounds like a lot like education. Is finance ever a limiting factor?
Oh, always. I think so. But I think, what I've seen, if equipment and things like that are done on the cheap, they don't last. And particularly in a hospital environment where you mightn't necessarily have a kitchen that everyone is, that they're chef led, like in hospitality. So the maintenance becomes an issue. So I think, but I guess overall, if the project's approved and you can show the cost savings, then that capital investment is worth it.
Okay, cool. Just very quickly, last one. From Jordan, I spent the last 24 hours in a Melbourne facility which utilised the system. Food was fantastic. Great work. The only weakness was the limiting to phone service only, and the limited hours that you can therefore order within. Is there options for stage technology uptake, such as QR and BYO device, possible within the new models that you've delivered?
Yeah, absolutely. So we're using BYOD, doing it at New South Wales Health Facility. In other private hospitals, we're using, we've got a meal ordering app. You can also use the QR code to take you to the platform for ordering via the app. So yeah, and also because of staff shortages, that's the way to go, to use the technology where you can.
Well, it sounds fantastic. I think you're 100% right. Education is probably the key to getting success, and the more people that talk about it and the more trials there are, the better. So I just want to thank you so much for your time, dedication to this area, and for your presentation tonight. Thank you to everyone who took the time to attend today. I know everyone's super busy with work and everything, so I just want to make sure that everyone, we thank and acknowledge everyone else. Just a few quick things before we leave. We've got early bird registrations for our conference, which is coming up in early November. This is the Australian Health Design Council Conference, which was a huge success last year. It's back again this year in Melbourne. We have we will be doing some site visits as well, and we have limited spots as well at the moment. We have contacted the successful people who have made it through to a site visit. We have contacted them. We will be contacting them. Registration for site visits are still open, and the first come service. So I think there's about 3 hospitals that we can actually explore. The Australian Health Design Council annual general meeting will be held in October this year during the first 15 minutes of the October webinar. Please keep an eye on emails as we share with you the information on how to nominate and how to vote for people on the council. We always encourage people with fresh ideas and a willingness to contribute to the health design industry to join our committee. There is always room for more, and there's always stuff to be done. Just quickly before we go, we've got the Australian Health Design Council podcast series, Health Design on the Go. The next series is coming out this week. It is the Future of Health series, which is about 7 speakers talking about the future of health and how models of care are going to be changing over the next few years, and how our design needs to change now for the future. Our next event will be on September 21, which is our next webinar. Please keep a placeholder in your calendar as we announce more details about events in the next couple of months. Podcasts will still continue to come out on a regular basis. Stay tuned for an update. As always, you can connect with us on our LinkedIn, tell your friends and family. We thank you so much for your time. And in closing, thank you for joining tonight's webinar. Thank you very much to Carmel. For those of you who would like to stay online and have an open Q&A with myself and Carmel, we'll be here for about 20 to 30 minutes. Otherwise, everyone have a good night and I'll see you soon. Thanks, everyone. Even though I'm in the dark. I don't know what happened to my sensor.
You're not moving enough.
No, maybe it's just the fact that there's no one in the office anymore.
And it's after hours as well.
Yeah, after hours, that's right.
Yeah, maybe that's the
Yeah, I
reason.
forgot about that, whether our office is alarmed.
Oh yeah, mine
time.
totally could be.
Right.
No one's definitely in our office this late. Thank you so much, Carmel. I think what's happened now, everyone's just going to join in who wants to join in, which is good. And we'll probably just go through a few simple, quick questions. I did have one quick more question for you before everyone jumps in. The barriers we talked to from a patient's, I'll go on to that one. Retrofitting got onto that one. From a sustainability point of view, you're talking about the wastage. So I know you said it's anywhere between 6 to 56%. But what was the reduction in waste?
So the reduction in plate waste. Most hospitals experience about 30 to 40% plate wastage. So that if you think about 30% each meal of wastage, hospitals that have implemented room service can be less than 10%. So if you think about restaurants generally, their wastage is sort of anywhere from 8 to 12%. So to get it at a level that plate wastage that's similar to restaurants and hospitality sector is pretty good.
Yeah, that's fantastic. And Leslie did ask the question. I just want to explore it a bit more. Like, I know there's long lead times for someone saying, yes, we love the idea to being implemented, but where does that, I imagine there's multiple resistance factors, but where do you think the biggest pain point is? Is it money? Is it education? Is it understanding? Is it infrastructure? Is it time? Is it buy-in? Is it time? Is it capacity? Like what is it, just everything? Or
I think about my experience. So if I think about, I first started sort of talking about room service in 2009 at St Vincent's, for example, and we got it in 2017. So if you think that's successful or not, but I think now it's probably easier in that there's a lot more sites